All right, welcome back to the Barbell Medicine Podcast. We have a very special guest this time, Dr. Bhattacharjee. He is a rheumatologist from Australia. Also have Dr. Baraki back with us. What's going on, Austin?
Doing great. I was just talking to Shom a little bit here about how I got a attending physician from my hospital to come and get coached with the main barbell lift today, so that's always good to do.
Yeah, and his fiance joined him?
Yes, yeah, she's I think either a PT or a PTA, and they're both wanting to learn about training. And as she was telling me about some of the patients she's worked with Parkinson's disease and stuff like that. So I think it's going to do some good things.
You know, that's a dangerous game, bringing your fiance with you who has previously trained at all. Because what if they lift more than you initially? I'm just saying, that's just it's a dangerous game. Shom, how's it going, man? What time is it over there? I feel like it's either middle of the night or
We've got this right this time, man. Things are going great. It's currently 11 o'clock in the morning on Monday, the 24th of July. It's actually a lovely winter's day outside, surprisingly. You guys must have brought the sunshine. It's a good thing.
That's right. So you're in Melbourne.
I'm in Melbourne, in Australia. That's right. Yes.
Okay. So it's the frozen tundra there. It's also Shom's also coming to us from the future. Apparently, it's tomorrow already. So
oh, no.
Okay. So Shom, let's we'll go through your kind of background first. So tell us about you. You're a rheumatologist. What does that even mean?
Correct. Yes. So I'm an attending physician in rheumatology and internal medicine. Rheumatology, just in case there may be some people out there who don't know what that is the branch of medicine that deals with arthritis and connective tissue diseases and that sort of thing. Basically, diseases of the immune system and musculoskeletal system. I'm not an orthopedic surgeon. I don't do any cutting, but I deal with the medical management of things like osteoarthritis and rheumatoid arthritis and various other kind of conditions. I'm dual trained with internal medicine, so I did all my undergraduate and postgraduate medicine in Melbourne. I've had some stints overseas. I've worked in the UK, in London, and a brief stint at the John Radcliffe Infirmary in Oxford. And I spent some time in the US, mainly doing observership stuff at Cedars-Sinai Hospital in Los Angeles many, many years ago now. Great city, LA. I don't know if I could live there long term, but it is a great city for what it's worth. Great fun place to visit.
Can confirm that LA is nice for short-term stay, but
yes. I think you have a unique perspective on that.
Yes.
Austin asked me earlier, in terms of lifting and that sort of thing, how long have I been training for and that sort of stuff. That's a great question. I'm trying to think of how to answer that question. Look, as a bit of disclosure, I entered med school quite early. I was 16 when I started, and here the medical curriculum is 6 years of undergrad when I did it, and then a whole bunch of postgraduate training, including what you call residency and things, until you get to being an attending. So I've been attending now for about 8 years, I think, and I finished my med school back in 2001. So it's a hell of a lot of time in between to put in some yards. So the reason for that is because I've been training or lifting weights in some capacity since I was 16, basically since I started university, and got lucky in that instead of doing the usual progress where, I trained to get as jacked as I could, which is always a fantastic goal, and I want to do that, I got introduced to the squat, bench press, deadlift, and overhead press really early in the piece, reading some stuff by Stuart McRobert, talking about, how to lift. These are the way to go. And I started off doing 20 rep squats and 20 rep deadlifts and that sort of stuff, which was a great way not to make much progress, but it was a good way to kind of get some form down. That wasn't too bad. In terms of proper training, though, after my first child was born, I kind of came around to starting strength, having not trained, trained intermittently in that time, and started to do something resembling a butchered linear progression, which I managed okay for a while. And then I did the time-honored tradition of cocking up the transition into intermediate programming and kind of spun my wheels for about 2 years until I met you, Dr. Feigenbaum. You came down to Melbourne, and I kind of I'd read a lot of what you'd written and liked kind of the way you approach things, and obviously very impressed with your lifts and that sort of stuff. And the same goes for you, Austin.
Thank you.
No, not at all. I mean it. I've got better things to do than blow smoke up your ass, man.
Well, if that's not a huge vote of confidence for barbell medicine programming, I don't know what is. So I'll have to
okay, man.
I'll have to
You're
pay you later.
Like $100 check. like it, right?
Yeah, 100 Australian dollars.
Of course not. US dollars, man. Come on, we got to It's all good. I want to put out that there's absolutely no financial kind of disclosure here. It's all good.
Oh, right. Yeah, I forgot. Now we'll have to start doing financial conflict of interest. Okay, so Shom, that's a good introduction, telling people about rheumatology, your training background. I think just to overall clarify, on your normal day-to-day, take us through what it's like. Is it mostly inpatient stuff, so inside the hospital? Is it outpatient? Are you seeing people in the clinic? Take us through your normal day.
Sure. Yeah, so that's a great question. I'm lucky to have quite varied days because my week is basically a 50-50 split of internal medicine and rheumatology stuff, and it's a good mix of inpatient and outpatient sort of stuff. I do a lot of perioperative stuff for orthopedic surgeons and urologists and things, so I do pre-op consults in my rooms and then see the patients through the operative phase and post-operatively and so forth. And rheumatology stuff is, very similar. In Australia, we have obviously public and private systems, which I think may be similar to what you have in the US as well. Mm-hmm. And so I have 2 public hospital appointments at 2 kind of different locations, and a range of private hospital appointments where I see consults, mainly as inpatient kind of things. There's a lot of call, a lot of teaching, registrar supervision, or what we call residency supervision and that sort of thing. And I do a lot of stuff with teaching outside of that because I examine for the College of Physicians, which is a very busy kind of time of year at the moment in particular. It tends to be reasonably longish days. I train, as you know, per the programming we have 6 days a week. So my day, irrespective of what's going on, starts with training. I'm usually up at 5, start training by 6, back home at 8, get my kids off to school, and then off to work once I've eaten and that sort of thing, and usually get home around 6.
So, and then this gets to be the humble brag sort of thing. So you wake up every morning at the crack of dawn, you get to go train, right? And yes. I think a lot of us who have been training for a long time just loathe training in the morning. It's the worst. But nevertheless, you've still been able to put up some pretty good numbers. So this is your humble brag time. You get to tell us your best numbers. And what's next on the agenda for as far as PRs go?
Well, right now I must say I'm in a bit of a funk because as Jordan knows, and I'm happy to expand on, I was actually unwell a couple of weeks ago. I got shingles down my arm, which was extraordinarily painful and has basically kicked my ass very, very hard. Prior to that, though, I currently weigh 77-ish or thereabouts. My best 1-rep squat was 180 kilos, which I think is about 4 or 5 pounds. Best 1-rep deadlift was 225, and best pause bench, just standard competition bench, was I think 125. I'm not anywhere near that ballpark right now, but I'm just happy to be back to training and getting through a training week without feeling like my arm's going to drop off. Yeah. It'll be a work in progress, but I'm hoping to get back there.
I feel like getting shingles at your age is unusual, right?
Yeah. I can assure you that I'm not carrying any infectious disease that can be communicated across the internet. So I'd be happy to undertake a randomized controlled trial in that regard. That could kind of be fun. No, look, I spoke with my ID colleague who was very kind in helping me kind of get onto antivirals and things. He's had it 4 times, and each time it's been at the apex of stress. And he's not a whole lot older than me. And he's not immunocompromised, and neither am I. So I think just being run down, keeping a high training output, having a lot of work-related stuff at this time of the year and that sort of thing, and probably not sleeping enough, taking a lot of calls. So combination of those things.
That's interesting, especially as it pertains to training, because we do, the big cohort of the folks that we work with, the big group is going to be, have some poor recovery based on their sleep and they have kids, and unless that stroller is for your pet, I believe that you got some kids back home. But they don't get shingles usually here, at least not that we're aware of. But we wonder why we have a few weeks of poor training, and I would imagine just something else is going on, and that kind of comports with our stress model. If your stress outstrips your recovery resources, what are you going to do?
Absolutely.
Yeah, you get shingles. Everyone else has some, their gains are delayed, quote unquote. And then, all right. And then, all right. So what is the most common thing that you see as a rheumatologist besides the pre-op stuff, which I assume is a lot of people who need either stress dose steroids or considerations for that? something like that?
Yeah, so actually the pre-op stuff's very varied. So it's they're not rheumatology patients necessarily having surgery. It's all kinds, So the usual kind of group of patients with ischemic heart disease and diabetes and all that sort of stuff, and just preoperative management of those various things.
Internal medicine stuff. I see.
Yeah, internal medicine stuff. Exactly. But yeah, absolutely. In the rheumatology context, of course, it's management of immunosuppression and of the adrenal stuff, as you've correctly elucidated. But to answer your question specifically, look. When people get into rheumatology residency, and I've interviewed for this on both sides quite a bit, it's usually the standard thing is, why do you want to do it? Because I love inflammatory stuff. I want to see all the immune stuff, the stuff that has all the cool drugs, rheumatoid arthritis, lupus, that kind of stuff. But in fact, the bulk of rheumatology is musculoskeletal medicine. So probably 60 to 70% of what I see is osteoarthritis or degenerative stuff, which I'm sure we'll expand on shortly. Mm-hmm. And the rest of it would be the inflammatory kind of stuff or the immune stuff.
Okay. Well, that's actually a nice segue and right into this osteoarthritis thing. Austin and I talked.
Nice saying, man.
Yeah,
tries.
Yeah, no kidding. I am gonna have to send you a check. We did for our first podcast about osteoarthritis and kind of review the literature and how we manage it now. You have this different perspective because you've seen your patient population is almost by definition more ill, or at least having more symptoms because they're getting referred to rheumatology, like at the time that they see you. So, the first person, if we see somebody who comes and wants training, we're like, well, they may have OA just like everybody else,
That's right.
But they haven't necessarily been to the rheumatologist yet. So what's your first, if you want to just a quick and dirty, what is OA? What is osteoarthritis? Who's the typical patient that you see, and then what do you do with them? Specifically, as it refers to musculoskeletal medicine, as far as training or whatever.
Sure. Yeah. So it's hard to cover everything, obviously, but in the interest of time, I'll keep it as brief as I can. Very broadly speaking, as you know, you can divide arthritis, which is just joint inflammation, into a degenerative kind, wear and tear, for want of a better term, and I guess the immune kind, or predominantly more inflammatory related stuff. It's more nuanced than this, obviously, and I'm not trying to insult any of my colleagues, but I think that's a fair way to kind of paint broad brushstrokes and make it relatable to people. In osteoarthritis, in essence, particularly of weight-bearing joints, you have loss of cartilage. Which is the stuff that normally keeps joints nice and well lubricated and able to move freely. Loss of cartilage leads to pain, particularly when people use the joint or put load through the joint, much more so than pain at rest, although both can coexist. Unlike the immune-related stuff, where the immune system misbehaves and decides in a fit of pique, if you like, to start attacking various bits of the joint and quite frequently other tissues outside the joint, it doesn't tend to respond to immune-suppressing kind of medications like prednisolone or methotrexate or any of those other kind of drugs. So from a pharmacological point of view, the kind of stuff we use for osteoarthritis would be things like non-steroidal anti-inflammatories, paracetamol or acetaminophen, as you call it, and other non-pharmacological things like glucosamine and fish oil and curcumin, many of which your listeners may be familiar with.
Sure. Now, so do you see a lot of OA or osteoarthritis coming to you being treated previously with a trial of steroids out of like a last-ditch effort kind of thing, or somebody?
Yeah, no, actually, I don't.
Okay.
Surprisingly, is that common in the US or?
I mean,
right, okay.
Yeah,
okay.
Yeah, it's quite common. For better or worse, and I think a quick look into the literature would dissuade people from doing that. How do people do with they don't do much better, but at the same time, the patient's there in the office and they're having a bunch of pain, and maybe you can't give them an injection. So just take this medication, maybe you'll feel better. But
even regardless of any joint specific effects of prednisone, for at least a few days, it'll probably make them feel pretty good.
Exactly. Yeah. Prednisone, as you know, is very much a feel-good kind of hormone. So absolutely, yes, I would agree with you. For depression management or outright psychosis, it's not a bad thing. Yeah.
It's a spectrum.
Yeah, that's right.
Osteoarthritis-induced psychosis. I like that. You need to take steroids. Okay. So you don't see much poor pharmaceutical management. All right. So they come to you and you've diagnosed them of having osteoarthritis more. So what's your sort of initial management? How do you treat them once they made their way to your office?
Yeah, sure. So look, I think any discussion about osteoarthritis should be prefaced, I think, and I'm pretty sure you guys went through this in your podcast as well, is that if you look at clinical trials of intervention in osteoarthritis and probably pain more generally, there's a very high placebo response, which means that, if I tell you that sucking on lollies is going to help your pain, and you have buy-in to that, and I'm a persuasive salesperson, which I am, then there's a 50% chance that you're going to believe in your pain is going to get better.
I was told that lollies do improve pain, so...
Excellent. You're a believer. That's fantastic. Live long and prosper, my friend.
Right.
And the corollary to that as well is that the natural history of pain that is non-malignant is to improve over a 6 to 8 week period or thereabouts. Assuming that you're not going out of your way to cause more damage and do things that are harmful to whatever stimulated the pain in the first place. So my general approach is to first kind of try and reassure people that it's pain, and pain exists for everybody. I'm living with pain now after this bout of shingles and all the rest of it, but that doesn't stop me necessarily doing the things I want to do. It's something that I can kind of control, and I can choose not to let the pain be a big factor in my life. It's not fun having it, but it can be managed. That's the first thing. Second thing is to say, to emphasize to patients, for me, that particularly for lower limb weight-bearing osteoarthritis, the one thing that correlates without fail with improvement in symptoms and long-term and reduction in long-term ill health or morbidity is the circumference of your quadriceps, i.e. the amount of lean mass that you're carrying around your quadriceps and thighs. That leads to a very nice segue to recommending training, because every patient that I see with osteoarthritis, I'm going to recommend that they start doing some kind of training. You asked earlier, what's the phenotype or what's the typical patient that I see with osteoarthritis? Oftentimes they're quite deconditioned, oftentimes they're quite overweight, and they tend to be on the older side. So I'd say over the age of 60, which I don't think is old at all, but for reference. That means, therefore, that getting them to undertake something reasonably specialized, like a barbell training program, is not an easy sell, because the initial reaction almost inevitably is, I'm going to hurt myself. So I start by doing simple things, just to improve, adherence and see how committed they are, by getting them to do fasted walks 3 times a week, first thing in the morning, to show them that they can exert some control and maybe even achieve some basic body composition changes. If they buy into that, then the next step I get them to do is stationary bike kind of stuff. Just escalating resistance, trying to run some kind of LP based on that. And concurrent with that, eventually, particularly for the right kind of patient that demonstrates some aptitude and or adherence, I'm going to refer them for barbell training.
Right.
Now, in a perfect world, I'd coach them, even though my coaching would be a real hack job. But I don't have the time. I don't think I have the aptitude like you guys do. So I have to resort to referring them to a local coach who is not a starting strength coach, but a reasonable coach nonetheless, and is familiar with the starting strength model. There are barriers to overcome there as well. He's located at one place. The patients are often far-flung, and they find it hard to get there and things. But in essence, referring for barbell training, incorporating the squat, bench press, deadlift, and overhead press is a key recommendation that I make to patients with osteoarthritis.
Well, I think we can just wrap this up. That's all we needed. That's the soundbite we did.
Fantastic. Yes, done.
Nailed it. No, I think it's interesting, and I don't want to misquote you or mischaracterize your recommendation. It sounds like you were trying to get some level of buy-in initially with them, just to kind of weed out, like, hey, I don't want to recommend this person, to go see my barbell guy, and and eat up their time if they're not even going to walk, right? They're not going to.
Yes.
Yeah, I see. So it sounds like, again, and I think you might have mentioned this perfectly. You said in a perfect world, I would have them, it'd be in the office. You'd have a starting strength coach. You'd have, all these resources that just aren't.
Sorry, and I missed that.
Oh, sorry. So it sounds like in a perfect world, you would have this gym in the office, and you would be able to coach them, or you would have somebody there, so there'd be less barriers to.
Absolutely.
Yeah.
It's funny. I was having this discussion with my dad just the other day, saying that my ideal setup would be exactly that. But I'd have my rooms, and I'd have a really nice, well-equipped, replete with Alico gear everywhere setup, which would be 100% tax deductible right next to my rooms. And life is good, right?
It sounds perfect. Now, Austin, you have an interesting thing as well, because you get to see. I don't think you've had any patients come to your gym yet, but you've had a lot of your colleagues, right? Come. Yeah. So, and what's been their general response? They ask you. So obviously, we're self-selecting for people who are motivated to train. What's been their response after exposure to the lifts?
You mean the patient's response?
No, so you haven't trained any patients. You've trained colleagues.
Yeah, so I haven't. No. I have. So I have not self-referred any patients to myself, but I've had colleagues who have referred their patients to me.
Oh, interesting.
Some of them I've trained, and additionally, I've had some folks come who I've coached, and they have various medical problems that I have to work around. I mentioned to you, recently I've worked with folks. I've plenty of folks with like metabolic syndrome. It's rampant in San Antonio here. Yeah. I recently worked with a gentleman who had a history of TBI, so like all kinds of different issues that I've had to work around from like a patient perspective. And yeah, I agree that it's to a degree selecting. I'm not able to get all the patients who would benefit from this to come and train. But I think that the initial response is that. Is that a fax machine or something? What's going on?
No, man, it's my housekeepers.
Okay.
Shom is on a different financial level than we are. He has a housekeeper.
Apparently.
So,
when you live in a shoebox, man, it's very easy to maintain.
Right. True. Fair enough.
The initial response that I typically get is just that they're always surprised that it was not necessarily what they expected. That they ended up feeling fine during the session, that it wasn't as scary or as hard or as painful or as terrifying as they thought barbells were. And they leave and they're as motivated as ever to do it. I've never had somebody who left and they're like, I don't think this is actually for me. So that's good.
Fun fact.
Look,
Oh, sorry.
I'm sorry for the comment.
Oh, so Dr. House, Hugh Laurie,
yes,
shows up to Horn Strength and Conditioning to do a session with Horn.
Wow.
That's awesome.
Yeah, Horn's like, do you know this guy? I'm like, I don't know him like personally or biblically, but I'm like a super fan, I just wanted to be like, it's lupus.
It's never lupus.
It's never, yeah. It turns out we have the rheumatologist who says it's never lupus.
Correct.
But apparently he had read the Starting Strength, book, and he was like really into it, and he just wanted a one-off coaching session, and then after having experienced it firsthand, he goes, it's pretty hard.
Well, that's unfortunate.
Yeah. But, that would have been really cool if House got jacked, House MD
Absolutely.
back, jacked, no cane, season 7.
Yeah. That's a fantastic plot twist at the end. Hey, he gets up and walks Lazarus like no cane and then does a perfect squat. That'd be great.
Yeah. So we were on the osteoarthritis thing, and I think a big question. So because we have a lot of people who are coaches and some medical folks who are listening, what would be your absolute contraindication for a patient who had osteoarthritis and no other sort of chronic conditions that they're really would affect their training status? What would be like an osteoarthritis kind of contraindication to loaded training, resistance training?
Yep. Look, it's kind of hard. I think it's important to draw a distinction between axial or spinal osteoarthritis versus the lower limb weight-bearing joint kind of osteoarthritis, as well as the peripheral kind of joints. All those three are different, I think, in their base etiologies and how they behave and respond to training. I think it's fair to say that if someone has really bad bone-on-bone hip or knee osteoarthritis, then prima facie, it's going to be very hard for them to squat or even to leg press effectively through a range of motion. Not to say they can't do it, but the level of discomfort that they experience, even using a hip-dominant model, like the Starting Strength model tends to teach, would still be, I think, a little bit of a difficult sell. I think if you had significant cervical spine osteoarthritis, sufficient to cause radiculopathy, which would make it hard for you to hold the bar, particularly across your back and keep it there. But I think that would be a relative contraindication to training. However, both of these things said, my general belief is that everyone who has any capacity to train should train. Because if you've got a good coach sitting there and supervising you and adequate spotting and lifting in a safe environment, like in a power rack, then I think there is always going to be both tangible and intangible system-wide benefits from increasing lean muscle mass and doing so in something that's efficient time-wise, and doesn't waste your time or anybody else's.
So that at that point, the benefits outweigh the risks.
In my opinion, yes.
Sure. Okay.
I was also thinking that this also presumes, when you mentioned that they have severe quote bone on bone in their knees or in their hips, that they have symptomatology that is kind of correlates
compatible
with that.
Absolutely, yes.
Because
definitely.
Plenty of people have bone on bone but don't have symptoms to reflect that sort of thing. At least radiographically speaking.
Yes, no, absolutely. And I think that's an important point that I make to patients as well, that the pain is a multifaceted thing. I think you covered that very elegantly in the article that you wrote for Mark Ripeto's website.
Yeah.
There are many inputs, nociceptive and otherwise, into someone's interpretation of pain. And I think absolutely there tends to be a disconnect in that you can have people with not terrible Kelvin-Lawrence grade osteoarthritis of the knee and terrible pain, and people with really bad grade 4 plus Kelvin-Lawrence osteoarthritis, and kind of getting by and managing.
Yeah.
My parents are a case in point. My mother in particular. With apologies for dragging my parents into this discussion, I'm sure they won't mind. Look, one of the things I say, and it gives me a lot of credibility with my patients, is that I make my parents train. I pay for them to go and see this barbell guy, and they train. My mother has very bad osteoarthritis of her knees radiographically, radiologically even on MRI. Periodically, she needs an injection into her knees, or I need to drain some fluid and that sort of thing, which is, I guess, one of the perks of having a son who's a rheumatologist.
Yeah.
But she trains. And, even though it's hard for her to squat and deadlift and that sort of thing, she always says to me she feels better when she trains. And she trains twice a week. And, both my parents are not athletic people. They're academics, amazingly academic people. But, they both say that their quality of life has improved immeasurably. So now it's become a self-fulfilling thing. And it's a great line, because I go to my patients, well, if it's good enough for my parents, it's good enough for my patients. And that's great, because that provokes quite a lot of buy-in. I think all these things are relative. And I think there are many things that you can do to train around whatever symptoms you have. And no matter what, in any patient who gets, let's say they've got really terrible osteoarthritis of their low limb weight-bearing joint. If you're going to go off and have an arthroplasty, the person that does best is the person that comes in with greater quadriceps and hamstring strength, the person who's going to fall less, the person who's going to rehab better, and make full use of that prosthesis. So the way I figure, it's all good.
It's not surprising that Ed Cohn has had both hips replaced and is still squatting mid-sixes. It's just came into it with great strength, and he tends to have a better outcome as a result. Yeah, it's not surprising.
You do better.
Yeah. It's just in the sky. That's great.
Yeah.
Sorry.
Also not surprising that Shom's parents are academics. Oh, be right back. Going into university at 16.
It's fair to say that I'm the black sheep of the family, man. My folks are like next level. So, yeah.
Wow.
Well, remind me not to ever purposely meet your parents, because my ego can't handle that. I'm too fragile.
My mother has a bone to pick with you, because she goes, who is this person that makes you train like this and keeps pushing you to lift heavy weights? And I said, well, he's not pushing me to do anything. I want to lift heavy weights.
Right.
Which doesn't exactly endear me to her either. So there you go. You're kind of off the hook, man.
I'm all right. Good. Okay. So, and I think this bears, mentioning. So osteoarthritis, would you classify this as inflammatory or a sort of destructive etiology as far as what causes osteoarthritis?
This is it's a terrific question. Look, I think the bottom line is, as with most things, the state of the science is evolving. I think increasingly we're going to find that there is, in fact, an immune or inflammatory component that starts off the process in the first place. And that will help explain, for example, why some people, even without doing a whole lot of repetitive sort of stuff involving loading of their joints, still get osteoarthritis, particularly at a young age. But mostly, I think for the sake of convenience, it's okay to say that it's a use-related thing, and it's degenerative with inflammation that happens as a result of that. I think the picture is much more nuanced than that, and that will hopefully be revealed in my lifetime, such that I have more effective treatments to offer patients than what I currently do.
Let it also be said that...
one of the concepts that I found super interesting when I was doing a bunch of work for the osteoarthritis thing was the phrase of metabolic osteoarthritis, when they refer to people with metabolic syndrome, and they kind of associate, that's a strong association, associating it with severe osteoarthritis of the hands, even in the absence. I mean, the fingers are not obviously like weight-bearing joints. You can do a lot of work with them, but I've seen some horrific erosive osteoarthritis in people's hands.
Yes.
And I'm like, what are you doing with your hands? But it's not anything like remarkable. It's just, their situation. And so that's kind of something we got into when we were differentiating molecular and cellular inflammation and things like that, and how that kind of has the impact. Because there has to be some mechanistic explanation for why things like NSAIDs and prednisone make some people feel better in some situations. You know what I mean? So there's something going on there that has some inflammation. It's just not the inflammation that we've historically recognized as, draining a bunch of white blood cells out of your knee, or, all that kind of stuff. So.
Absolutely. No, I think that is very elegantly put. And indeed, there is a phenotype of osteoarthritis that is inflammatory or erosive osteoarthritis of the hands. And without, again, boring your listeners, for all intents and purposes, even though the evidence base isn't great, we tend to manage that the way we would immune-related inflammatory arthritis, using prednisolone and injections and chemotherapy-type drugs like methotrexate or that sort of thing, and sometimes anti-cytokine-based therapy. To your point about metabolic syndrome, as you know, fat and muscle are both metabolically active tissues. Broadly speaking, I think it's fair to say, even though I'm sure I know it's more nuanced than this, that fat can be the greater fat mass you carry, the more inflammatory kind of compounds or chemicals.
Yeah,
that's right. Yes, are produced, and I think those have system-wide effects that are often very deleterious and contribute not just to metabolic syndrome, but to various other consequences like osteoarthritis and indeed inflammatory arthritis. Equally, I think the more lean mass you carry, the more anti-inflammatory, if you like, kind of cytokines and chemicals are produced. And I think that overall, that's one of the reasons why people who carry more lean mass generally tend to have less morbidity for a whole bunch of reasons.
Yeah,
I'd like to also point out that I'm not the only one who says the word nuanced. Just like to say.
I knew that was coming.
And then, and also I think what I'm hearing you say is that everyone needs to be on a gluten-free, high fish oil diet in order to control for inflammatories.
Okay, so look, I'm going to say something slightly inflammatory. I think that there are many people that buy into the whole idea of having celiac disease or being gluten sensitive and that sort of thing, when in fact there's no objective evidence that they have gluten sensitivity or indeed outright celiac disease. Again, I think there is a significant placebo component for many of these people. I think if you truly have celiac disease or true gluten sensitivity, then it makes perfect sense for you to be on a gluten-free or low-gluten diet. But I don't have a problem if people do that and it makes them feel better. Again, the placebo response is 50%. So if that makes you feel better and allows you to train and gives you good quality of life, then, go for it. As far as fish oil goes, a lot of the research on fish oil was done at the University of South Australia. So I'm kind of a believer, even though the overall evidence is not terribly favorable, that it does very much. I think if you don't have like an iodine problem, because fish oil has a lot of iodine, and you don't have a fish allergy, and you want to try it, I'm happy. I don't mind if people do that at 3 grams a day.
Okay. Now, as from the research I did for this, the osteoarthritis original episode, and just prior to that, the evidence is better for RA, the rheumatic kind of.
Yeah, that's right. For inflammatory conditions, yes, correct.
Versus,
correct,
but
right.
but for osteoarthritis, not as good unless you're. The placebo effect is. And it's interesting, you would say that we're trying to leverage if we're holistic practitioners, we're trying to leverage the placebo effect as much as possible, and I kind of side with you in that if it's going to work or help. We can find out, and the risks are pretty low, unless you're being prescribed like Lovaza in the United States. It's $3,500 a year for fish oil, which seems a little high, year. So there's some cost associated with it that is different than just taking your over-the-counter.
Yeah. Look, I completely agree with you. I'm all about leveraging the placebo effect where it's safe and not a significant financial impost for a patient to do so.
Sure.
$3,500. Hey, I've got bridges I want to sell then.
Right. Okay. So as we kind of make our way down here, so do you see a lot of patients who come in with arthritic pain?
I'm sorry, I missed that.
Sorry. Do you see a lot of patients who come in with joint pain due to gout? Do you see a lot of gouty patients that are referred your way?
Oh, yes.
Okay.
Yes, absolutely.
What do you do with them? Because we have this kind of interesting sort of situation where you probably want to get them to train, but then there's the concern of a protein intake and then the actual erosive lesions at the joints. What's your kind of take on what do you do with a gout patient as far as training?
Yeah. So if it's okay, for the benefit of your listeners, I might just very quickly talk about what gout is.
Sure.
So I have, in the interest of disclosure here, I got approached by Men's Health magazine to do a little thing on gout not that long ago. Men's Health magazine in the US, as it turns out.
Excuse me.
I was completely shirted for that interview. Can I say? Because I published in gout. So gout is a very old inflammatory disease. It's been around for a very long time, Roman age, and probably even beyond that. It's caused by crystals of a kind called uric acid. And uric acid is ubiquitous. It's found, we have it naturally, and it comes from a component of protein-rich foods in particular called a purine. The way the body metabolizes a purine results in the creation of uric acid, if you like, and it manifests as joint pain that has been likened since the 1600s to being so painful that it's like walking on your own eyeballs with knives in them.
Oh, yikes.
Jesus.
The typical joint that's affected in gout tends to be your lower limb joints, far from the center of the body. And I think it has to do with core temperature as much as anything else, because low body temperatures or low temperatures in general result in uric acid precipitating. And when it precipitates, it causes an intense inflammatory response, which leads to joint pain, swelling, redness, and basically disability. It tends to be the big toe often that's affected, particularly on the left-hand side for reasons I can't expound on. But basically, most joints in the body can be affected by it, including the spine, interestingly enough. The one thing about gout is we know the mechanism behind it really, really well, and it is deeply satisfying to treat. There are many there's some pharmacological ways and non-pharmacological ways to approach it. To answer your question, a high-protein diet, prima facie, should be an increased risk for production of purines and for causing hyperuricemia. Let me give you some disclosure here. So my dad has gout, and he's on appropriate treatment to lower his uric acid. He supplements with whey, because I make him supplement with whey protein. And he drinks, an adequate fluid intake. He's not had an attack of gout since he's been training at all, including in summer months and all the rest of it. And I would not classify him as someone who is particularly adherent to the fluid prescription that I've given.
Sure.
He's extremely non-adherent, I think it's fair to say.
And to be clear, I think that you would probably say that not all, but many of your colleagues would find such a prescription to supplement with whey protein to be heretical in a patient with gout.
Absolutely, absolutely. So I take the decision away from them. I buy it from when I stack up a month. I buy them extra stuff. So this is what you're going to take. Yeah, it's great.
Okay.
I mean, and just for the listeners' sake, I mean, I work with a handful of patients or people with gout for nutrition-wise. They get referred to me, and I've seen it obviously in the clinic during residency. And my reading on it is such that, I mean, when you look at the studies, they have specific inflection points of gouty attacks at particular protein levels. And so you start getting scared to say, hey, eat more than 125 grams of protein a day, for instance. And so that kind of caused me to make the recommendation, well, if we keep it at 125 and then supplement with BCAAs, free-form BCAAs with meals, you can get a good effect out of that. But effectively what you're telling me is that your dad, even though going above probably that level of protein intake, is doing just fine, which, I mean, of course there's multiple mechanisms going into why purines will precipitate.
Absolutely.
Yeah.
Yes.
So,
yes.
Okay. But, it's just interesting that the data.
It's an interesting anecdote.
Yeah.
Yeah. I mean, it's as with all these things, it's nuanced, to use a word that both of you enjoy so much.
Yes.
My dad, is, for all intents and purposes, he's very compliant with taking his gout medication. So that's one good thing. His uric acid levels are at a range in blood when he gets them tested, such that his probability of getting a gout attack would be low to begin with. But interestingly, it has not changed in the time that he's been training and supplementing with whey. I think he takes an extra 60 or 70 grams of whey protein a day, give or take. So I can't remember.
Sure.
But it's there. The situation may be very different to someone with more brittle gout who is non-adherent to their pharmacological treatment, which is using medicines like allopurinol or Xyloprim, who has a very high intake of alcohol-related purines, so particularly beers and that sort of thing. My dad doesn't really tend to drink much alcohol. And my dad does not have tophi, which is the buildup of when you've had gout or high uric acid levels for so long that the uric acid no longer just sits in the joints, but it crystallizes and precipitates in the skin. All of those things, I think, may well alter your sensitivity to developing a gout episode. I mean, it stands to reason, right? If you've got more severe phenotype, then odds are it will take less to piss off your gout.
Yeah. If you're listening to this, this is for entertainment purposes only. Do not take this recommendations as medical treatment. Please talk to your doctor. Yeah, we are doctors, but we are not your doctors. Unless we are, in which case you should ask us.
I'm not.
Right, yeah, Shom is not, probably.
Yeah. So, but I do think that there is an important role for training. Austin mentioned the metabolic syndrome before. Gout is very strongly associated with the metabolic syndrome. I think hyperuricemia is a marker of oxidative stress. I think one great way to reduce oxidative stress is, again, to train, to improve your aerobic capacity, to improve your anaerobic capacity, improve lean mass, change your cytokine profile, and do all those good things that come with it. Again, you asked, to reference back to your question earlier about contraindications to training. I think it'd be really hard for someone with very bad tophaceous gout around the elbow, around the finger joints, around the feet and things, to be able to train effectively, because balance is affected, pain is affected. Those things can get infected if they break down. But given enough time to establish remission of their gout using the appropriate medications, things like allopurinol, you can get dissolution of those tophi.
Right.
You can make them softer, and you can reduce the chances of gout flares. All those things, I think, gradually make the case for introducing some training. And I think barbell training is the way to go.
So just, you would, if you had somebody in an acute flare, they probably wouldn't be able to train, and then
they're not going to be doing anything.
Obvious.
Yeah. Well, that's just the thing, though. Well, I know, imagine somebody, a starting strength coach, who is, familiar with the coaching method, but not necessarily familiar with these medical sort of conditions, and
Sure.
and so they may have a person, and on their intake questionnaire it says, history of gout flare, and the person's like, oh crap, And so what you're saying is that, somebody may have a history of gout flare, but if they don't have an acute one right now, they can probably still train. And the idea is they're going to continue to follow up with their doctor anyway, but they'd probably be okay to train despite having history of gout flare at some point. But if they're acutely, I like that term, tophaceous gout. What I was saying is that there's no contraindication to training if just with a history of gout.
No, not at all. So look, I think it's context sensitive, right? Just like anything else. If you're asking about past history and someone says they had a single attack of gout 6 months ago, but they've been kind of okay since then, well, that's, as far as I'm concerned, that's not it. That's a no-brainer. They should train, but they should pay extra attention to their hydration, which you kind of advise them from a nutritional point of view anyway. And I would be cautious with up-titrating the protein supplementation. Starting with, say, 125 grams or thereabouts, and just adding in, but make it a kind of an LP, if you like, a linear progression of their protein. Yeah, just to see what they can tolerate. At some point, you're going to work it out, right?
Yeah, LPOP. So, I like it.
Yeah,
I like it. Trademarked. Yeah, right. I'll give you royalties. And then this is kind of there's two other kind of rheumatology-specific disease processes I kind of wanted to address. One is this ankylosing spondylitis, and classically we learn it's this young guy with back pain gets better, with training. Do you see that a lot? Or
Yeah.
Okay. So,
yeah, absolutely, frequently. In fact, in Australia at the moment, I'll take one step back. Of the 5 drugs in 2015 worldwide with sales above $5 billion, right? 4 of them are rheumatology-specific drugs. They're anti-TNF based kind of things. So we are very valuable as a group to the drug companies as a result.
Marketing shit.
Part of the reason that's right, yes. I'm independent, of course, because I'm an honorable man. But the reason that they're the best-selling drugs is A, they're very expensive, but B, they also work and give us treatment options that we didn't previously have. For ankylosing spondylitis in particular, some of these drugs have absolutely revolutionized the symptomatology that patients experience. I don't know yet whether they fully alter the disease process sufficient to give someone a normal life expectancy and no flares and that kind of stuff. It's not a cure by any means, but in terms of day-to-day symptoms, some of the results I've seen with these drugs for these kind of patients has been unbelievable. The reason I mention that is because the drug companies are obviously, one of the things that they're most interested in is gaining more market share and, of course, providing community service and things as they go along doing that. And the companies that make these drugs have made a very concerted effort in Australia in recent months to raise awareness about ankylosing spondylitis. You guys know what cricket is, right?
Cricket, the cell phone stuff?
The sport.
Cricket. The sport. All right. Yeah.
So, not being pejorative at all. It's very popular, and there's a particularly renowned Australian cricketer who has ankylosing spondylitis, who has been a very effective spokesperson for some of the drug companies that make these particular drugs for them. So I think the awareness of Ankspon in general has gone up, and that can only be a good thing, because the earlier people get referred in general to specialists like myself or my colleagues, the better we might be able to manage it, and the earlier we might be able to intervene before these changes affecting the back become insurmountable. So in a roundabout way, I guess that leads to, well, why do we want to intervene and what symptoms are there? So you're absolutely right. Ankylosing spondylitis is an inflammatory disease. The immune system, for reasons that we don't fully understand and lots of billions of dollars are researching, goes into this kind of overdrive mode to attack various bits around some of the spinal joints, particularly the ones at the very bottom of the spine called the sacroiliac joints, which is basically where your spine meets your pelvis. That leads to symptoms of what that we characterize as inflammatory back pain, which is exactly as you said, back pain that is significantly associated with a long period of stiffness in the morning, so it's worse after rest, tends to get better with exercise. So the typical person would be a young guy who is very athletic and things and feels not bad when they play, but feels absolutely mashed when they finish playing. So be it basketball, tennis, cricket, what have you, Interestingly enough, anti-inflammatories, non-steroidal anti-inflammatories like diclofenac or naproxen and that sort of thing seem to make maybe disease-modifying, but certainly make, to a variable extent, quite a difference in terms of people's symptoms. They say when I take these kind of anti-inflammatories, I feel pretty good. If I take them at night, I wake up feeling not quite so stiff. In the long term, if it's left untreated over many, many years, we sometimes see people who, referencing a classic Simpsons character, become sort of Mr. Burns. They get the sort of flattening of the curve of their back. They get hunched over. They get a whole lot of movement. And I always think of the Mr. Burns analogy because it's a great way to kind of remember that. There's a lot of systemic symptomatology associated with this as well. People get very, very fatigued very easily, and this really plays havoc with their quality of lives and can really result in very high health-related quality of life morbidity and cost the economy thereof. The good news is that some of these very high-cost drugs make an enormous difference, not just to the appearance of the joints when you do x-rays and things, but also in terms of the symptomatology. People report that they can actually move. They have significantly less early morning stiffness, much more energy, less peripheral joint pain, and just overall they just feel $1 million, a whole lot better than any of the conventional kind of drugs most of the time.
So I added this ankylosing spondylitis to our list of things to talk about, mainly because I've coached two people who had it, and they came to me, fortunately, having already been essentially cleared by their rheumatologist to train. They said that it was okay. I don't think that they had been on biologics yet. They had been on lesser forms of immunosuppression. I think maybe one of them took like azathioprine or something like that. But he said that he was okay to train. He was being monitored and everything, and so we trained him, and he did great. And I just found it to be interesting because that's not something that I see cases of it here and there. I saw more cases of it when I was actually in a rheumatology clinic, but outside of that, we don't see it a whole lot. And so it was neat to see that they were able to train essentially unhindered from my perspective.
Yeah, absolutely, Austin. I think that's wonderful that you've had that experience as well. Referencing Jordan's question before, some people are going to say, well, are there people with Ankspon who can't train or who shouldn't train? Look, I think if you have Ankspon of sufficient duration and severity, such that you have what we call a bamboo spine, where you have bone bridges that are formed literally between the vertebrae, there's pretty persuasive evidence suggesting that those kind of patients have more brittle bones and they're more prone to fractures, particularly of a kind we call green stick sort of fractures. It's more relevant if you're doing ballistic type movements, so power clean, power snatch, that sort of stuff, or where you have a high balance component and high force production component. I think those patients I would have some hesitation in recommending they do those ballistic type movements, but I think a controlled movement like the squat or the deadlift or bench press or even overhead press, I think provided that they were able to start with some kind of weight that they could handle, and you could kind of test the waters, so to speak, and run them on a very carefully supervised linear progression, I think that would be a very good thing for them, because they need more bone mass, they need more muscle mass, just like the next guy. And I don't think that will be a major contraindication for them.
Well, there you have it, folks. You can train. Doesn't matter what medical conditions you have. You just keep training, and it's just fine. No, that makes sense, and it also makes sense that if you're able to incrementally load and controlled movement, it seems like, if you got to live with it anyway, this just makes you symptomatically probably better, functions, activities of daily life improve, your functionality scores improve, you're probably less depressed because you're training. That's all. I know, we referenced some of the medications just in general, the biologics and anti-inflammatories and stuff like that. Probably the first question I would ask, because this recently just came up on a small website called Facebook, and we were talking about the Ibuprofen Protocol. Okay, so ibuprofen, non-steroidal anti-inflammatory drug, and we have the starting strength community had it at some point said, oh, there's the Ibuprofen Protocol. You can just take 800 milligrams a day or something like that for 5 days, which isn't the max dose, but there's evidence, as you know, that's out there suggesting the cardiovascular risk for taking ibuprofen long term. Well,
I'm sorry, Matt. I just missed that.
Oh, it's fine. So there's evidence out there suggesting that if you take ibuprofen long term, there's a cardiovascular risk, and obviously the GI risk of taking ibuprofen long term. What do you make of that? And then if you had to give people a takeaway on their ibuprofen usage, if you had a gun to your head, what would you say?
But this is really hard. There's the data on the cardiovascular risk stuff. I think is real. There is a small but measurable increased risk of cardiovascular disease and mortality with, I think, any exposure, even short term, to anti-inflammatories. But does that mean that nobody should take anti-inflammatories? I would put it to you that if I had a patient in whom taking a low dose of anti-inflammatories, say, to give you one example, someone with osteoarthritis who really wants to train or just really wants to walk to maintain their body composition and maintain some degree of fitness, if they could take, say, a low dose of meloxicam or something like that, like a long-acting non-steroidal anti-inflammatory, and that allowed them to get out and do that kind of stuff, probably, in my opinion, I don't have facts necessarily to back this up, but I feel that their overall risk would probably balance out in terms of risk versus benefit. Equally, if you had a young, healthy person who tweaks something, like a back or a shoulder or that sort of thing, and they want to take anti-inflammatories for a short period, like a week or thereabouts, doing it properly, so, having it with meals, and trying to not smoke and drink copious quantities of alcohol, do other things to increase their cardiovascular risk, probably that would be okay for the short term. It doesn't necessarily, everyone who takes anti-inflammatories outside of chronic high-dose use, I don't think is going to end up like Alonzo Mourning, for example, having 2 kidney transplants and analgesic nephropathy. At least 1 kidney transplant. I don't recall the exact details now. So my general feel is short-term use is okay. Like with most of these things, I think it's fair to say, in general with medicine, you want to take the minimum quantity of drug for the minimum length of time to avoid side effects. That doesn't mean you can wrap yourself up in a bubble, because otherwise these drugs wouldn't exist, because they do work, in inverted commas. They relieve symptoms, And I think it permits you to getting some quality of life back, and equally allows you to be somewhat introspective about looking to what caused the injury in the first place and trying to mitigate that, then that's probably okay.
So you would be okay with taking those medications for a short period of time if needed, and if we're taking other steps to reduce risk overall of any side effect. I think that makes sense. And
okay.
And especially if it's being used as a way to facilitate the thing that'll provide more quote-unquote definitive management. Right. Like an osteoarthritis patient takes it so they train. Over the long term, their training makes their knees better.
Sure.
There you go.
Sure.
Absolutely correct. Absolutely correct.
Are there any medications that you routinely prescribe or see that would have a deleterious effect on training that you know of? I don't know if you've actually done some research on any of the medications you see that actually affect folks' training progress. I'll give you one anecdote. What's that?
Prednisone.
Well, prednisone, yeah. But as far as that affecting, so you've seen research that shows that prednisone, it's obviously can be myotoxic, but as far as the strength, I haven't seen any strength outcomes being tested on prednisone.
Likewise. Neither have I.
And like sirolimus or whatever, I was just looking to see if there's like a muscle protein synthesis kind of like, and nobody's evaluating because no one cares. We're the only ones who are like, I wonder what happens to my bicep cross-sectional area if I start taking it. So
is this a cue for you to go shirtless now?
And so the Instagram Live.
Well, look, again, great question. I think the problem is that this is sufficient sufficiently niche in mainstream medicine that there's not a whole lot of people doing this particular kind of research. But I think we can maybe draw some intuitive conclusions that may or may not be wrong. A reminder of the old anecdote that you might have been told in your first day of med school, which is that 50% of what the person's going to tell, or whatever you're going to be taught in med school is wrong, but we just don't know which 50% that is. The state of the science evolves. So with that caveat, steroids are the obvious, so not anabolic steroids, but I guess what you might call catabolic steroids, prednisolone and prednisone and derivatives like that, in high doses, which I would say 1 milligram per kilogram or more, can be associated with weakening of tendons, so tendon rupture. It can be myopathic, absolutely, as you both have seen. Patients who are on chronic long-term steroids tend to lose muscle mass around their hip and shoulder girdles, which leads to them having difficulty squatting, getting out of a chair, that kind of stuff. Having said that, is that a contraindication? I think that if you could train, although if you did it unsupervised and didn't have a good handle on how to measure your fatigue and training stress, your risk of injury is higher. But equally, if you did it in a supervised way and/or you were training with some miles under your belt, sufficient to kind of gauge what your training stress is, I think that would probably be a good thing, because I think that might well actually mitigate the myopathic effects and the tendon-related effects. The cytokine treatments are an interesting one. I know from research in inflammatory myopathies, things like polymyositis and dermatomyositis, that, and in what little exercise physiology research I've read, that the inflammatory cytokines, interleukin-6 and TNF-alpha, tumor necrosis factor alpha, are quite helpful to actually drive the regenerative process in muscle. So I guess the adaptation part of the SAR model that we use. Prima facie, many of our anti-cytokine therapies, sophisticated biological therapies, block these cytokines because they also cause inflammation. Therefore, it may be the case that patients on these kind of therapies may have a more blunted adaptation response to training. Again, though, I think it's a much more complex picture than that, because if you've got someone who has uncontrolled inflammatory disease and you bring that disease under control using these medications such that their recovery is likely to be better, probably it all evens out in the end. Their progress might be a little bit slower than the unhindered or unencumbered trainee, if you like, of the same age, same training kind of status and that sort of thing. But overall, I think it's still a good thing for them to train, and they'd probably derive some benefits out of it. In trainees, I guess training in a commercial gym environment, training hard, and not providing enough attention to recovery, I suppose there's the risk of picking up infections and things. I'm a case in point. I mean, I'm not immunocompromised. I got shingles, and that's a reactivation, so it's a different thing. But they may be more susceptible to infections and things just because of the kind of training load they're under. But again, that can be manipulated. You can dose the stress appropriately such that and track various metrics to make sure they're getting the right outcome out of that. Neuropathic pain agents and antidepressants have various interesting effects on the central nervous system, which might mean that patients can't execute particularly ballistic lifts as cleanly as they otherwise would. But again, I don't think that applies to the big lifts as we define them, or as I think you guys define them, the squat, bench press, deadlift, overhead press. So there's the obvious ones. If you're on like cyclophosphamide as infusional kind of protocol and things, you're going to feel pretty crappy. And that's a huge understatement. But again, I have read anecdotally of people who try and train in some way, shape, or form, even if it's doing bodyweight stuff or push-ups or planks or what have you. I don't think that's a bad thing. I think, in fact, if anything, that's probably an underexplored area to help reduce the terrible effects or side effects that these drugs have.
Yeah, I mean, they have data on similar types of things, whether it be physical therapy or whatever kind of exercise modality in oncology patients who are on chemotherapy, and you are effectively, it's just you're just using rheumatology chemotherapy on patients as opposed to anti-tumor chemotherapy. So, correct.
Yeah, I think what I'm hearing you say, Shom, is that you're about to start a randomized controlled trial of patients who are on steroids who are training, and then patients who are on steroids who are not training, and then you can just gauge their outcomes, and then you can write.
Absolutely.
Yeah, I think that's what I'm hearing.
Absolutely. You say. I think the outcomes there is going to be the thigh to buy ratio or the general jackitude. I think that would be a good thing. Am I allowed to say that?
I think thigh to buy ratio. I like that. I like that.
DBR.
Yeah, we're still trying to suss out what the gains score is. We need to come up with our criteria and then, our scale.
Yeah, gains coefficient, man. That's what we need. It's like the Gini coefficient, but applied to,
We were in med school and we were trying to come up with a scoring, like a point system, just like all these other like medicine scores that we have, CHADS and all this other stuff. I was trying to come up with a gain score, and we came close, but it wasn't one that was satisfying. So we need to go back to the drawing board on that.
Yeah, we'll have to.
Well, look, I desperately hope to read in your up-to-date article that you have a gain score because, hey, man, that's going to revolutionize things. No matter what kind of calculator.
Yeah, that'd be perfect. Yeah, if we have a calculator that makes it on MD Calc, I think we've made it. So
yeah, made it absolutely.
There's already a Feigenbaum constant. It's a physics/mathematical term, so I can't really use that. So I think it'll just have to be gains, and that's fine. I'll just put a mark after it. It's totally fine.
It rolls off the tongue so beautifully as well.
It really does, and I just if I see gains in medical notes, I feel like I've made it. Like that's the point. We've made it.
All right, I'm going to have to make it my goal this week to dictate a letter somewhere where I write gains, spelled with 3 Zs.
If you put 3 Zs in there, oh man, perfect. All right. Well, hey, Shom, I really have to thank you for joining us. This is a start of we're going to have some medical professionals on here. Our next one is a psychiatrist, so he's going to psychoanalyze your actual interview. So you're just going to be exposed to that.
Mm-hmm. It's okay, man. I already know that I'm really messed up. It's just going to confirm. Yeah.
We'll send a copy to your parents.
Inferiority complex from his parents, exactly.
Yeah, and now that we know that you're already more popular than we are, since you were in Men's Health, maybe we'll leverage your stardom to jump to the next level. So,
I haven't followed up on that, and I don't even know when it's going to be published. But someone did take the trouble to have this Skype consult with me, like a Skype interview with me. So there you go. It's out there somewhere.
You might be the only rheumatologist in the world who squats 405. So.
That's actually
like literally. I bet that is the case.
Is Shom the strongest rheumatologist in the world?
That's gonna be his subtitle for his article.
Yeah, that's what it's gonna be. I think when I go back and edit this, Shom's the strongest rheumatologist in the world until proven otherwise. So listen, folks, if you know a rheumatologist who squats 406, don't tell us because honestly, this is a great.
Yeah, I'm gonna have to take him or her out. That's just not on.
Send him shingles. Perfect. All right. Well, yeah. Thanks for joining us, Austin. It was great having you as well. I'll stitch this guy together, and thanks for your time, guys. I really appreciate it.
Not at all. Thank you. It's been a pleasure. Take care.
All right, fellas. See you guys.
All the best.